with nodules, when you find one, like let's just put ourselves in a proximal osteal cert, we always find these nodules. If you find a nodule there, how does that influence sort of what you do, or does it influence what you do?
Yeah, I think, as I said, it pushes me more towards doing some dedicated calcium modification above NC balloons. As well as the fact that we're talking about them, I feel like over the last, let's say, 5+ years, every, calcium modification tool has had its period of time where people say this is this should be your approach for nodules. So there was a time that everyone said do orbital for nodules because it would orbit around and it would, be less susceptible to the wire bias and you would be able to modify the lesion. There were times when people said do rotational atherectomy, but at lower RPMs, again, to try and, get more, interaction with the nodule. I mean, the truth is that all atherectomy is completely predicated on the wire bias. And so if the wire bias takes you away from the nodule, you may do zero calcium modification with your atherectomy. And there are limited things you can do to manipulate your wire bias. Really, all you can do is change the wire for, different wire support, let's say rotational support wire, or use a guide or guide extension to try and manipulate the wire bias. I have started, the other thing, and I think people should, realize is you very rarely get a calcified nodule in isolation. When you get a calcified nodule, you're very likely to have other calcium patterns adjacent to it within the artery. I will typically now, my approach, and we have to be honest that there's not a tremendous amount of data to guide us, is that if it's a very tight, then I will do atherectomy up front. And then I will nearly always augment it with IVL. IVL is not vulnerable to wire bias, so it's independent of wire bias. And I feel like it is the only technology that, at least conceptually or in theory, can get through that surface of the nodule towards the base of the nodule, which then may allow you to displace the nodule better with your follow-on balloons and stents, and then will give you hopefully the greater MSA. The other thing that I do with nodules, and again, this is not evidence-based, but kind of, intuition or logic, is I do use the higher radial force, thicker strut stents, because I have seen cases that have been treated, very well, righteously image-guided calcium modification, stented with a good result in a calcified nodule. And they come back, weeks later with the nodule kind of protruding through. And so I do try and use the stronger stents, the higher radial force, thicker strut stents when I treat nodules. And if they do recur after stenting, it's the one scenario of kind of like early stent failure that you want to add an extra layer of stent. It's nothing to do with the drug or anti-proliferative effect. You just need more, physical barrier to the nodule there.
Yeah, there's something about those bases on the recalcitrant nodules where it is one of the hardest things for me to know what to do with often is these, left main bifurcations where we've got a circ stent in, and we've done a 2-stent bifurcation technique, and just that proximal osteal, it's this recalcitrant nodule that comes back up, right, and re-protrudes into the stent strut. Those are really hard to treat. One, from a physics standpoint of getting back through the lesion and getting gear to follow, because that's often your daughter, that you've done a DK mini crash, maybe a culotte, depending, and hopefully you kissed out the carina really well, because getting back in is just hard. I think that DCBs have potentially changed that a bit for me. I don't do a lot of 2-stent strategies anymore, just with the availability of DCBs, particularly my left main bifurcations these days. But that might be an area where you need that radial force. I mean, I've had friends overseas telling me, well, actually, those are areas where you need the radial force. And yet we're left with crushed stent 4-6 months later. So is that the answer? I still really don't know. I think there's a lot of interest in this sort of IVL followed by DCB. I've certainly done my fair share of those cases where I'll IVL a severely calcified lesion, get good modification, and DCB it, and wonder, is that the right thing? Again, it's a little unclear, because I also, to your point, I don't have an MSA necessarily to shoot for in that area. So when I look, I just sort of say, well, it's 30% or less the NOST, so I guess I'm okay. But yeah, that's still definitely an area for a lot of future therapeutics to be directed towards.
Have you changed your left main stenting? A lot of people have talked about actually treating the circ as the parent branch and the LAD as the daughter branch, for angulation purposes, or to avoid this scenario where you have this crushed metal there. Have you started doing that?
Well, that's what my mentor from training, Bill Lombardi, really likes to do. Is he likes to treat the LAD as the daughter and the circ as the parent from an angle standpoint, just because you're always able to get into the LAD a bit easier. And I think it makes a lot of sense. I don't think you see that adopted in many other practices, in terms of people always worry about the myocardial distribution of the LAD compared to the circ and the potential prognostic significance that can have in terms of jeopardy with 2 layers of stent essentially over the ostium. I think it really depends. I think that the biggest thing is the proximal circ big enough for that stent to cross from the left main end? Because I don't do really ostial stent, or well, I'll never say
Yeah.
never, because the world is a complex, tough place. But I will say I really, really, really work hard to avoid sort of nailing the ostium. It just doesn't work. The imaging
Yeah.
studies are pretty clear. You miss the ostium at least a third of the time, if not more. And so the proximal circ's got to be big enough to take a stent that's going to be able to expand enough in the left main within that scaffold to not fracture. And so you've got to really legitimately have to have at least a 3.5 proximal circ to make it work. With the advent of some of these stents like Megatron and things like that, they've got large expansive portfolios, although so does Xience these days. That's becoming a little bit less of an issue, but it's got to be big enough to make sense. The other thing is you can culotte, right? There's a lot of great European
Yep.
data with left main culotte as a primary strategy there. I think most of us in the States still favor DK crush based on the older DK crush trials, but I think there's still very much a role there as well, just depending. But I'll tell you, I have really shied away from 2-stent strategies these days with drug-coated balloons being on the shelf.
Yep.
I haven't done a left main 2-stent bifurcation in a while, just because I really tried to just use the DCB for the circ. I don't feel like I've had enough time under my belt to know if that's how efficacious that is. Any week, I could come back and one of my partners is going to be like, hey man, you got to go deal with this left main. You didn't stent the circ. You got to go deal with this now. So I'm just waiting for that phone call. I mean, I hope it doesn't come, but I feel like some of the stuff I'm doing where I really don't know. I'm just waiting to see where the chips fall. But to this point, I've really tried to try to avoid that. And
Yeah.
particularly with these calcified left main bifurcations, I think as long as you get good vessel prep, DCB may be the way, but I just don't know.
Yeah. I mean, I guess also, if you're prepping it in a way that is unlikely or less likely to cause significant dissection, then you are much more comfortable leaving it without the scaffold of the stent behind and just kind of coating with the DCB.
Yeah, I'll tell you, scouring the different countries sort of, because now other countries have been using DCBs long enough where they're coming out with consensus statements and things like that for people like me to read and sort of be like, what, how do I do this? And I remember I was reading, there was one out of Asia a handful of months ago that I was reading, and it was very much like, if you have a dissection, but it's not limiting flow with DCB therapy, you're good. And I'm sort of reading that, I'm like, so, then in practice, I'm going in there and I've got like this proximal LAD with a clear dissection after DCB treatment. I'm watching the TIMI 3 flow. I'm like, okay, so I'm supposed to leave this.
Yeah.
Am I going to get thrown under the bus for this? But, anyway,
Yeah.
up to this point, everything's been okay. But certainly an interesting time where you have calcium modification therapies along with other novel formal treatment strategies that now we're starting to mix and match and wonder what is the right sort of milieu in order to get, optimal patient outcomes.